and then I'll introduce. Olá a todos, bem-vindos a mais uma Osteotalks. Desta vez temos o ilustre convidado Christian Lunghi. A Osteotalks tem o nome de renovação dos modelos osteopáticos de estrutura e função, portanto, renovação destas ideias, destes conceitos osteopáticos de estrutura e função, pela reconceitualização do conceito de disfunção somática, por aquilo que se fala muito hoje em dia dos cuidados osteopáticos centrados no paciente. E, portanto, no fundo, reconceitualizar esta ideia de conceito de disfunção somática, um termo muito abrangente e muito vago também, por ideias mais recentes sobre esta, enfim, recente nas últimas décadas, esta ideia de a centralidade de ser no paciente dos cuidados osteopáticos. De resto, a origem da osteopatia fala nesta ideia da centralidade do paciente, mas depois na prática, de facto, não é muito isso que vimos tanto no ensino como na prática clínica. Então é sobre isso que vamos discutir. Christian Lunghi, DO, osteopata, docente e investigador, esteve envolvido nos processos de regulamentação da osteopatia em Itália, é autor e coautor de livros, publicações em revistas indexadas, e é basicamente sobre 3 destes papers do Christian Lunghi. Um deles é o primeiro autor, papers recentes de 2021 e 2022, que vamos girar, vai girar a nossa conversa. Há um primeiro paper de 2022 que se chama Patient Active Approaches in Osteopathic Practice, Scoping Review. As referências bibliográficas vão estar disponíveis depois nas redes sociais e YouTube. Há um outro paper de 2021, The Role of Touch in Osteopathic Practice, a Narrative Review, and Integrative Hypothesis, e há um outro paper chama-se com o nome de Osteopathic Structure Function Models, Renovation for a Person-Centered Approach. Basicamente o mesmo título que dá ao título deste podcast, desta Osteotalk. A Narrative Review and an Integrative Hypothesis. So I did an introduction, and I'll just start with this question, and relating this last paper I mentioned in 2021, the Osteopathic Structure Function Models Renovation for a Person-Centered Approach. You wrote right in the beginning of the article, you guys wrote, the present review highlights the limited amount of literature on using osteopathic conceptual models in decision-making and treatment strategies. A research plan is required to develop a common framework for an evidence-based osteopathic practice that promotes well-being in an interdisciplinary person-centered care process. Sorry, I'm a bit tired. It's been a long day. My question is this. So I just paraphrased a part of your paper, that it feels for me that highlights a very important point. And one of the things I really enjoy about this podcast is it gives me the opportunity to talk with so many guests and to really go into depth of many of the doubts, questions, concerns, constraints that our profession has. I think since decades, and so challenging and shaking the concepts, established concepts, the belief system, like dysfunction. What is dysfunction? It's a clinical word, dysfunction. It's not new, but what is somatic dysfunction? What exactly does it describe? Exactly what? And is it different for me and different for you and different for this university and for the other? With the recent or the last decades, the idea that pain sciences explain pain in a different way that it was explained 20 years ago, and there's kind of a professional identity which is not only in osteopathy. It feels like in many manual therapies, in many hands-on therapies and exercise therapies. There's sort of identity crisis in terms of these areas, osteopathy, physiotherapy, physical therapy, exercise, they're kind of getting together, and it's hard to draw a line, or where do osteopathy starts and it ends, and So going back to the paper and to this maybe professional identity or professional reconceptualization, maybe that is needed. The question is, my first question, I always take a long time to ask a question, I'm sorry. My question is there a lack of consensus in terms of diagnosis and osteopathic reasoning criteria, in your opinion?
First of all, thank you.
Thank you for being here. Thank you.
Yeah, to invite me here to talk with you, all of you, and for your question, because that's, in my point of view, that is the take-home message of that contemporary time for us as osteopath and as a profession. That, as you told us, we are now in a time in which we are maybe ready to work together, because you can see sometime that we are confused in terms of professional profiles of physiotherapists, osteopathy, but you can, if you look at from another point of view, you can see an interprofessional way of manage the same person. And when you work really in team with other professionals for a person, there are some competencies that if one day, let's say I'm the physio, you are the osteo, one day you are not there. So it's good if we are working together with that person, that I know some things, that I have some tools of your profession, because we are working together with that person. When we speak about distinctive character of a profession, our idea is what is the real answer, the real work you do to answer as a specific profession to health needs and to the quality of health services. Because, okay, we are quite the same, we have interprofessional skills and competencies, but if there are no there is no distinctive character, there is no need for a profession. So there's just maybe an healthcare professionals that is physio, osteo, chiropractic all together. In our experience, and it was not just a politic issue, because scientific community in Italy ask us and ask them together, is that profession really needed in terms of health needs and the quality of health services? Because we have physiotherapists, for instance, that has manual therapy in their skills, in their competencies. It's not just a political issue, it's to ask ourselves, is that profession needed? So when we speak in terms of reconceptualization of the models, and also we involve inside the concept of somatic dysfunction, we speak in terms of, reconceptualization in terms of defining a distinctive way of the profession to do something, maybe for the same aim, but maybe not, because most of the time, in my point of view, the health allied professions are focused on the disease. We had a long journey during this 150 years old, since the beginning, speaking about disease. But most of the time, if we look into the discussion, we are really focused more more on the illness, more on the patient experience of the disease, not so much into the anatomopathological alterations. In fact, the idea of the osteopathic structure function models that some of the guys who worked in the United States developing that used to call structure function environment models, because the idea was to unlock the brain of the osteopaths from the biomechanical, the mechanical issues. The idea was to say there is a dysfunction, so an alteration of a self-regulative function related to a body, mind, and spirit difficulties to be integrated.
That's can I just say something?
Yeah.
Very quick. It's so funny because I recently heard, or someone told me that, you know, there's a school, a French kind of school, whatever, osteopath, that doesn't really uses the word dysfunction because they don't agree on dysfunction. They use the word restriction. But what you just said is just something that makes so much sense, which is dysfunction is a much broader characterization, a much broader idea of something is wrong, something is not in homeostasis, something is probably in allostasis load, which is not just the somatic system, it's not just the muscular system.
No, it's not.
And that's what Andrew Taylor Still was actually talking about since the beginning.
Yeah, and maybe at the beginning it was more in terms of 5 regions in the body. But speaking with the first few guys, Hildreth, McConnell, Tasker, Hewlett, they were yeah, it's not. It's that we have at the beginning 3 functions: neural function. Yeah, they put together breathing pattern and circulation, and there is the mind, okay, in their idea. So that was the drive for that 5 areas. In the discussion, they tried to do something a little bit more understandable for the clinicians. So 3 region, not 3 function and 5 region, 5 function and 5 region in the body. Then we have now 10. But going back to the definition, without going so far, if we go in the glossary, you have alterated function. And alterated function in the osteopathic field is not biomechanical. It's biomechanical, okay, neurological, circulatory, respiratory, metabolic, and psychological function. So you can have psychological alteration that is not a disease. It's more like an illness. It's more like patient perception, patient psychological responsiveness, or the other responsiveness related in patient perception to a region or more than a region, maybe the entire body, because they used to talk in terms of total osteopathic dysfunction. If we go back to the definition, then you have the body framework. But if you have just a body framework, inflammation signs, so the tissue alteration, tissue changes, the asymmetry, the restriction of mobility and tenderness, it's not a dysfunction. It is a dysfunction for the basic definition if it is related to an alterated function that could be psychological, metabolic. It is, in other terms, the way to say we are not working on a disease, we are working focused on the person, and the meaning of the word working with the person is improving, maintaining the self-regulative functions, because those are expression of the body, mind, and spirit integration with the environment. That was the idea. I'm okay. We need to reconceptualize, but saying that the structure function models are, for instance, to be dismissed. Okay, I've never seen in the osteopathic European curriculum the structure function model in the basic training. I don't know in Portugal now, but how can I say we have to dismiss something that nobody studied in the training? Because most of the times, speaking about models, reconceptualization in the mind of our colleagues, reconceptualize visceral, craniosacral, and structural osteopathy. That's not speaking about models. It's not structure, function, environment models.
It's actually almost a sin, because when we start it's really upsetting actually when we hear, and when I read or hear cranial osteopathy, visceral osteopathy. It's almost like a paradox, because it doesn't make any sense.
Where's the person?
Yes, and a global intervention does not separate a person into cranium or into viscera or into bones, so it doesn't, but it's not really, I mean, in the universities I teach, for instance, now in Piaget, which is in the south, the Alexandre Nunes, I think you know Alexandre Nunes from COM, and he talks about models, and we both talk actually about the 5 models, and other biopsychosocial model, of course. And in the other university in Lisbon I used to teach, I also go into the 5. I really, there's something about the 5 models, the breathing, the biomechanical, neurological, which really goes well with the treatment itself, with the practical. When you try to include everything, like stimulating the neuro part and the biomechanical part, and when I can explain the symptoms and the signs of the patient, the integration of the circular, the vascular flow, the neuroimmune responses, hypothetically, at the same time with the biomechanical issues, and at the same time with the patient beliefs or experience, I think it creates such a harmonic treatment that I really enjoy. But it can be
let me say that one of the aim of the paper you mentioned was to speak with the clinicians. So there is an appendix also in the other one, about patient active approaches, what we call patient active approaches, or interactive approaches, if you like. It was one of the aim was to speak with clinicians, because we're not here to say this is the way to act. This is just an example according to osteopathic principle, maybe a little bit looking at what is going on now. I'm personally, I feel absolutely aligned with the inactive approach, and I feel that the renovated structure function environment models a lot close with the inactivism. The difference is, for me, the inactivism, for instance, it's an umbrella, a conceptual umbrella for all the health allied professions. Maybe structure, function, environment models tell us in which way osteopathic practitioners use that idea. Because let's use inactivism as an example, but we can use pain science as well. Inactivism speaks to us in terms of you have a predictionary model of the environment that drives your movement, external movement, musculoskeletal movement, but also secretions. So inherent movement. If you have a model, oh, the environment is red, your movement is red. You act like red, and your blood and your breathing pattern, it's theoretically coherent with the model of the environment. You go outside, the environment, it's not like the model, and you have uncertainty. The uncertainty of the musculoskeletal movement, biomechanical function, and of the other function. So the idea is that maybe osteopaths can be the one of the health profession that can improve the structure function interdependence, driving to act a little bit more close to the environment. So personally, I don't feel too much far from that.
And in one of the papers, the last paper, the patient active approaches in osteopathic practice, you actually give examples and of what could be this patient-centered osteopathic care and in this patient active osteopathic approaches. And you mentioned you like, for instance, gamification and problem
Gamification, yeah.
Interactive dyadic approach. This is something we talked about with Francesco also, this
Yes.
dyadic approach, this even the touch and being present and guiding the patient could be, and bringing the patient to do games or movements that is fear-based or something like this. Mindfulness-based exercise, where your mind is, where your focus is, where you're aiming, integrated mental imagery. So all of this are actually coherent with this idea that the patient and the environment are kind of one, and there's a dyad between the osteopath and the patient. Yeah. We can work in that frame.
And you know what? Also in that paper about patient active approaches, we mentioned, for instance, somatic dysfunction, but it's not somatic dysfunction. It's not what is sometimes called restriction, lesion. Well, it's not about something in the structure. It's something in a body functions, also psychological function, related in terms of patient perception to a region. Yeah. I definitely can use that region or that movement pattern, a generalized pattern, with the patient, with gamification, for instance, to improve body awareness, and renovate patient model of the environment, make the patient more far from the uncertainty in the movement.
Yep.
So, but probably when we speak about somatic dysfunction, we speak in a different language from other guys.
Yeah.
Because of course,
I actually taught a class last year with the name of Somatic Dysfunction. Someone asked me to do, it was a semester, and the course, and I took the term, and I started my class like this. There was a paper, the British Medical Journal, and the guy, a construction worker, had a metal nail through his foot and through his boot. And when he fell, so he fell and he got a nail, a metal nail, punctured, perforated his boot, and he could see the nail sticking out. He rushed into the hospital. They took him to the hospital. He was in severe pain, and he couldn't even move with pain. And when they took the boot out and the nail, there was not even a skin injury it just went between the toes and was nothing, and he got the most severe pain. So I started the class like that, and it's so nice to see what is this dysfunction exactly. It's really about how the brain predicts and how the brain interprets the feedback, interoception, exteroception. And the new sciences, pain sciences and neurosciences, has shown that actually some neurogenesis occur, for instance, in the hippocampus related with memory, based on error and making it right and then erroring. So this type of things we can actually do in the practice, which is, for instance, bringing the patients to do some sort of movements and correcting the movements, guiding the movements, acting, helping to do the movements. And you talk about this actually, like when you say fascial. What do you say? Active fascial.
Yeah, the idea is we, in a shared decision making with the patient, we selected some type of touch. Maybe we selected also a region or an area to deliver the biological and psychological effect of touch. And what we call somatic dysfunction, it was defined with the patient. So there's an agreement between the osteopath and the patient. The patient sometimes has not the ability to give you a verbal responsiveness, positive responsiveness. Let's think about a baby or an elderly people with cognitive, not really a proper cognitive ability, or let's say people with persistent pain has no how can I say, body awareness, not good body awareness. So finding a region or an area or a pattern of movement that the patient that help the patient doing a daily gesture or improving some functional tests is a non-verbal communication way to let the patient feel the meaning of what you are doing there. Then you can verbalize with some people. What about now if I touch in this way? And we try to address with the hands-on treatment, and just a little bit after, try to define the same aim with an active approach, let's say with an exercise. But our hand is there. If I use an area to deliver the effect of touch, I try to put the attention of the patient, the awareness of the patient. If you move that area in that way, let's do it again, and let the patient have the perception of that maybe is a little bit more safe. But it's not that that area is the cause of the illness. It's the opposite. It's an opportunity. You have the opportunity moving in a different way, sometimes thanks to me, because I can, with you, both we can have the perception of that maybe that area is useful to deliver the effect of touch, psychological and biological, but you can do yourself. Try again. That's an idea to let the patient be involved into. And when the patient just have the perception that something is present, oh, now it's better. You open up. You can augment the perfusion in the orbitofrontal cortex, because in the opposite, if you do your own what you like because it's wrong, it's there is a rotated vertebra, the patient is thinking, okay, what you're doing there, I have pain in the other side, doesn't understand. You increase the perfusion in the amygdala. Maybe the patient is worry about what you're doing and the effect of touch doesn't work. So that's to simplify, that's the idea.
Yeah. And just to finalize, I know you're in a bit of a hurry. So I thank you so much for your time. I just I think you share the same opinion, and so, sometimes it's difficult to include all of this in one topic or in one discussion, in one model. Let's say, I'm not sure.
Yeah.
But I think that's what you're trying to do, and your team and the people you write with. So usually, as I'm not sure. I mean, it's just an idea I have, but it's something that I do think about, which is brain sciences, neurosciences. This idea of a prediction, of active inference, of fear, pain. It's not related. It's an experience. It's a subjective experience, not related with lesions. Maybe not related with lesions. Not only, at least, all of this in activism. It all makes very much sense as a pain education, but the patient being active for sure, being reassured, confident, blah blah blah, and but at the same time, we cannot deny ever, I think, the what happens in terms of the at the cellular level, at the biological level, at the cellular matrix. Whenever there's injuries, we can look clearly into phenomena of angiogenesis, inflammation, tissue disorganization, and we know that manual therapies, we know this for 40 years, manual therapy do stimulate new collagen organization, production, blah, 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 blah. So we do have an influence on tissue changes. And being in nerves, for instance, neural mobilization, neurodynamics, it's very well proven. Being in the muscles, in the tendons, whatever. And sometimes there's a bit of maybe not confusion, but sometimes I don't know exactly what's going to do to the professional identity if we don't involve in the discussion of what we do and what's our job and what are our influences in terms of and differences in terms of treatment. If we don't include also in this new neurosciences approaches, we don't include also the actual manual stimulation on a specific tissue in a specific way, and we can actually create changes in the tissues, not just mind body perception.
Absolutely agree, Bruno, because we can say, okay, it's enough, biopsychosocial model, include everything. Okay, if you include everything, okay, the part bio, in my point of view, is well explained, and the interaction between the part bio and the psycho and the social is well explained in the structure, function, environment models, for instance. Also, the concept of somatic dysfunction, it's the relationship between self-regulative function, first of all, psychological, and the body framework. But that relationship is not in terms of cause effect. It's the opposite. It's thus the possibility to interact with a function, maybe by touch or movement, involving a region of the body or the entire body, a pattern, a movement pattern, is better for that person with respect of another movement pattern. A region could be better to deliver the effect of touch with respect of another region for that specific person. I don't know, but what I know is that we definitely need a consensus inside our community of practice, because having a consensus, having an osteotalk, a global osteotalk, we can maybe sometimes it's difficult to explain with just one guy, maybe in a group or in a paper, maybe in a group, you can share your idea, your experience according to. And it's another things that you mentioned is that maybe we have to say, to write and to specify what we do. Yeah, definitely yes, because it's ethical. It's ethical and it's respectful with respect of the other professionals. Because of course there are interprofessional competencies, but to have another profession, you need a specific competence, core competence for that profession. That's my point of view. That is what I want to share with other guys, all of you of the community of practice involving clinicians, not just researchers, teachers, because we need to have a common framework that all of us are comfortable with, and most of all first of all the patients.
Yeah, because it just feels like there's an evolution of the profession which comes the last years. I think mainly because of COM. I'm not sure if it's mainly just COM, but I think COM had a really big impact, and of course the journals, the Osteopathic journal, the IJOM, International Journal of Osteopathic Medicine, all of this, but researchers like you, like writers like you, like researchers like George, Francisco, all of the team in COM has such a, this in the last years, there's so many papers have been produced, and so much of this discussion has been out there. And it's so quick and it's so fast, and it feels like the evolution of the profession, it's not at the same pace, but it's so diverse. There's actually osteopaths that introduce themselves as osteopaths, but they talk about so many other things that are not related with the profession at all. It's just mainly their own spiritual beliefs, or whatever it is. And it just sometimes it just feels, I know Portugal, for instance, is a newly regulated profession in Portugal, but it's almost like we're not part of the same identities. Like we're so, and it's actually it's frightening, because it looks like a weak profession. And like you said in the beginning of the discussion, there's actually a political discussion. Do we need osteopathy? I remember, just to finish, I know, I'm sorry, I took a bit of time. Just to finish, in 2016, I think 16-17, I was the president of an association in Portugal. Now it's the biggest association in Portugal. And I remember going to a meeting in A3ES, which is the regulatory body for honors, bachelor honors, all the bachelor honors degrees in all the universities, and the top guy, or one of the top guys at this institution, he said, I honestly don't understand why osteopathy was regulated, because from my point of view, which I don't understand anything about the profession, just the regulation of the courses, of the degrees, how are they conducted, all of that thing. But I really don't understand why osteopathy did not went inside or became the same, part of the same profession as, for instance, physiotherapy. In my eyes, you guys, you all do the same. and this is something that is really, really important. This professional identity brings strength, and the strength brings that
what you said, it's not just a political issue in my point of view, it's also an ethical issue, so it's a scientific issue. We need to reflect on that. Not all the reflection tonight.
Of course
Have your rest, but all together.
And it's very late. It's you were an hour ahead, so I forgot it's 9:40. So thank you so much for your time, and it's always a pleasure to talk to you and to hear your reflections. Thank you for accepting, and I'm sorry for being so late. I hope you have a nice rest. If you're like me, you wake up at 5:30 in the morning, 6. So so I totally understand you. Thank you so much.
Our training.
Thank you.
Enjoy your night, and
you
thank you again. And I wait you to organize the worldwide Osteotalk.
Now you give me something to think about. Thank you so much. Bye bye.
Ciao.
Ciao.